circulation of blood through the body by way of cardiac cycles. Now, hopefully by the end of this session, we should be able, or you guys should be able, to tell me the 3 layers of the heart, also the 4 chambers, and other features that you find inside and outside of the heart, such as the valves, the blood vessels. Also, she was able to tell me how to trace the blood through the heart, through the chambers of the heart, and out through various vessels. Also, be able to distinguish the arteries that nourish the myocardium and the veins that drain into it, as well as dealing with the SA node and how it fires, and also the conduction, the electrical conduction of the heart, and also be able to just interpret a normal EKG. Various structures we'll go over, the P wave, QRS, we'll get there, and you need to let me know. You need to know exactly what's happening at that point in time when you see a P wave on the EKG machine. What does that mean? So this is the very first video of 3 videos for this particular chapter on the heart. So your book talks about various scholars back in the day that were discovering the heart. Back in the day, the Chinese, Egyptians, and the Greek Romans, they thought that the heart was just a pump that was filling up vessels with blood. Not much of an understanding, but it was a start. Then in the 3rd century, they started to come along and started describing they started realizing that the heart actually gets nourished by various blood vessels. Not only does it pump blood, but it also gets pump blood. The heart doesn't only pump blood to the various organs and tissues, it also receives blood. By the 16th century, they've had a great improvement dealing with the cardiovascular anatomy, and started dipping into various diseases and treatments for the cardiovascular system. By the 20th century, we've come a very long way where we're using various medicines such as digitalis. We are able to distinguish the different types of abnormal heart rhythms and of course find treatments for these things. Even surgery has come a long way when it comes to the heart. So cardiology is one of today's most dramatic, attention-getting fields in medicine. So the cardiovascular system and the circulatory system, what is the difference between the two? You might think, oh, this is the same thing. Sort of. But when we talk about the cardiovascular system, we're talking about just the heart and the blood vessels. When we look at the circulatory system, we look at the heart, blood vessels, and the blood. So that's why chapter 9 is entitled the circulatory system, because chapter 19, 18, and 20 are entitled the circulatory system, because those are the 3 main components dealing with the circulatory system. Now, the cardiovascular system has 2 main divisions. You have a pulmonary circuit, which deals with just the right side of the heart, and that carries blood to the lungs for gas exchange and then back to the heart. The systemic system deals with just the left side of the heart, and that supplies oxygenated blood to all the tissues of the body and then returns it to the heart. So the pulmonary side, that right side of the heart, is just dealing with deoxygenated blood, because if the blood has to get to the heart for gas exchange, it's picking up oxygen from the lungs. So that's why the right side of the heart deals with deoxygenated blood and the left side deals with oxygenated blood. Oh, I went ahead of myself. Alright, so the 2 sides, the left side of the heart, as I said, fully oxygenated blood, it arrives from the lungs via the pulmonary veins. So this is after it has picked up oxygen So here's the left side of the heart. It's picking up oxygen from the lungs and taking it back into the heart, full of oxygen. When it does that, of course, blood is sent to all the organs, through the aorta, through the upper extremity and the lower extremities. When it takes it there, it goes through another gas exchange, taking us back to the right side of the heart. So this is our deoxygenated blood. That's returning to the heart from the inferior vena cava and the superior vena cava. So then the blood will be sent to the lungs via the pulmonary trunk, which is here. There are left and right pulmonary veins, sent back through to the lungs so that it can receive oxygen and get rid of our carbon dioxide. So our left side deals with oxygenated blood, and our right side deals with deoxygenated blood. Okay, let's move on to the next slide. Position, size, and shape of the heart. The heart is located in the thoracic cavity in the mediastinum between the lungs and deep in between in the sternum. You see it sitting right in here in this particular position. It is tilted towards the left from superior to inferior midpoints. So about 2/3 of the heart lies to the left of the median line. The broad portion, which you see up top here, this is considered to be, let me see here, this is the base of the heart. And then that pointy end is called the apex. And this is just above our diaphragm. Put the rest of this inwards. Okay, so you see the measurements here that I have for the base. The base is 3.5 inches wide and 2 and 5 inches from the base to the apex. And then the apex from anterior to posterior, so that's the front to the back, that's just 2.5 inches. So if you ever have a measuring tape, just pull out the measuring tape and you'll see, get 5 inches and you'll see that's the approximate distance from the apex to, from the base to the apex is approximately 5 inches. So here's another diagram of the heart, this cross section. And we'll see right here, here is the mediastinum. Now what is mediastinum? Now that's the space in the chest between the pleural sacs of the lungs that contains all of the tissues and the organs of the chest except the lungs and the pleurae. So you see how the heart is situated closely to the left and right lungs in that small pericardial cavity. So not much space in between them. So let's look at some other structures. We have the pericardium. It is a doubled walled sac that encloses the heart. Now the outer wall is called the pericardial sac, and that's also called the parietal pericardium, and that has a tough fibrous layer of dense irregular connective tissue and a deep thin serous layer. Now the serous layer, it turns inward at the base of the heart to form the epicardium, which also called the visceral pericardium, that covers the heart's surface. Now the pericardial sac is anchored by ligaments to the diaphragm and the sternum, and by fibrous connective tissue to the mediastinal tissue. And here is the pericardial cavity. This pericardial cavity This is that space between the parietal and the visceral membranes, and it's filled with approximately 5 to 30 milliliters of pericardial fluid. Now, if there's inflammation with those membranes, that's called pericarditis, and that's when the membranes will produce a very painful friction rub with every heartbeat. So every time the heart beats, you're gonna have a lot of pain within your chest. Now, the pericardium isolates the heart from other thoracic organs and allows it room to expand while resisting excessive expansion. So here's a closer look at the pericardial cavity and the pericardium. But here is the pericardium right here. Remember, that's a double wall sac that's going to enclose that's going to enclose the heart. So here we have the connection at the bottom where it attaches, or its ligaments are going to extend and anchor to the diaphragm. And then at the top we have it also anchoring to part of the blood vessels here. And it also anchors to the I said it before, to the sternum. Okay, so here's anchoring to the diaphragm and the sternum, which is in front. It is part of the rib cage. Hope you remember your anatomy, your skeletal system. All right, so let's move on to the visceral. I talked about the visceral pericardium. That is that second layer of the pericardial, the pericardium, and that's the one that's going to enclose the heart. It's actually going to come into contact with the heart. So it's that first layer. So to backtrack just a little bit, the heart consists of 3 layers. It has the epicardium, the myocardium, and the endocardium. Okay, so it has that. Let's move on. Let me continue because I didn't get excited with this. The epicardium, which also called the visceral pericardium, is a serous membrane on the heart surface. It's mainly simple squamous epithelium, and it overlaying a thin layer of areolar tissue. Now, in some places it has a thick layer of adipose tissue, but in other areas it is fat-free and translucent, so you're able to see the heart itself. In some areas you have some adipose tissue. The largest branch of coronary blood vessels travel through the epicardium. So the fat, there's nothing wrong with having, there's nothing wrong with having fat within the body. Adipose tissue is good there for insulation. The next one is our endocardium. Our endocardium is similar and lines the interior of the heart chambers. That's my endocardium. Here it is right here. This is the one that lines the chambers. It's not just on the outside, but it's the entire thing inside. It lines everything. Now it has a similar structure but has no adipose tissue. And it covers the valve surfaces and is continuous with the endothelium of the blood vessels. The myocardium is between the other 2 layers. So that's this right here. This is my myocardium. And it's composed of cardiac muscle and is the thickest layer. It performs the work of the heart. Now, its thickness varies from one heart chamber to another and is proportional to the workload. So here, this chamber here, which we'll get to, this is our left ventricle, and this is our left aorta. But you notice the thickness is different down here in the apex region close to the left ventricle than it is by the atrium. Now its muscle spirals around the heart, forming a myocardial vortex. So upon contraction, a twisting or ringing motion will occur. So I hope you guys remember the three layers, the main three layers. We have the epicardium, also called the visceral pericardium. We have the endocardium and the myocardium. And this whole heart is encased by the pericardium. Okay? And between the pericardium and the visceral pericardium, also called the epicardium, is our pericardium cavity, which carries fluid, 5 to 30 milliliters of fluid within there. Okay? So the heart has a framework of collagenous and elastic fibers that make up the fibrous skeleton. This tissue is especially concentrated in the walls between the heart chambers, in fibrous rings around the valves, and in sheets of tissue that interconnect these rings. Right, so let's look at the functions of the fibrous skeleton. It provides structural support, especially around the valves and the openings of the great vessels. Let's change to the next slide so you can actually get a visual of what I'm referring to. So the first one is it provides structural support, especially around the valves and openings of the great vessels. Okay, here's our valve here. There's 4 valves. Okay, it anchors, those are fibrous tissue here, fibrous skeleton. It anchors the cardiac muscle cells or cardiocytes and provides leverage. It serves as electrical insulation between the atria and the ventricles. Its elastic recoil can aid in refilling the heart with blood after each heartbeat. Now the heart has 4 chambers. We have 2 atria, a left and a right, and we have 2 ventricles, a left and a right. Now, if I say atrium, that refers to just one. So we have 2 atria, but 1 atrium. Now, the 2 chambers at the top, which would be at the superior aspect by the base, are the left and the right atria. They are thin-walled and receive blood returning to the heart by way of the great veins. Most of its mass is on the posterior side of the heart, and in the anterior view, and has a small air-like extension called an auricle that slightly increases the volume. Now, the 2 lower chambers are inferior chambers of the left and right ventricles, and those are the pumps. They're going to eject the blood into the arteries. The right ventricle constitutes most of the anterior aspect of the heart. This is my right one. So obviously when you do a cross section, you're going to see the right one more than you see the left, because the left ventricle, it will form the apex and the inferior posterior aspect. So inferior meaning low, posterior meaning behind. So you have most of it in the posterior view, behind the heart. You see most of it from a posterior view. Now on the surface, 3 sulci or grooves mark the boundaries of the 4 chambers. These sulci are largely filled by fat, and the largest of the coronary blood vessels. The coronary sulcus, also called the atrioventricular sulcus, it encircles the heart near the base. So here is our atrioventricular sulci. okay, also called the coronary sinus. Now, the other two sulci, they extend obliquely down the heart, so that's at an angle obliquely, down the heart, from the sulcus sinus toward the apex. Here they are. Now, they are branching off here as well. Now, the one on the front is the anterior interventricular sulcus. The one on the back is called the posterior interventricular sulcus. These two sulci overlie an internal wall, the interventricular septum, and that septum is what divides the left and right ventricle. So here is our posterior interventricular sulcus, and if you remember what in the diagram of the heart, there was a little thick structure that separated the left and right ventricle. That's my interventricular septum, which I think I have in another diagram, which I'll get to. But this is basically going to overlie on the internal wall of it. So basically, this is where the interventricular is on the inner aspect of the heart. Now the atria have thin, flaccid walls corresponding to the relative lightweight workload of pumping blood into the ventricles. Now they are separated by a wall called the interatrium septum. The right atrium and both auricles, they exhibit internal ridges of myocardium called pectinate muscles. Now the ventricles are separated by the interventricular septum, a much more muscular vertical wall. The right ventricle pumps blood to the lungs and is only moderately muscular. The left wall is 2 or more times as thick, and it pumps blood through the entire body. Now both ventricles exhibit internal ridges called trabeculae carnae. So when you look at the heart, and in another diagram, I'll show it to you guys again. It looks a little bumpy, and that's considered, those little ridges, or those little bumps, those are considered the trabeculae carnae. Here it is. So see these ridges in here in both the ventricles and the aorta? Sorry, the ventricles and the atria. Those are the trabeculae carnae. Okay? Now, this entire structure here, it's a big chamber, so it's like a little hole. This entire thing is called the right ventricle. The one here may look small, but it's a lot larger. This is called the left ventricle. And you notice that the wall, the myocardium, is a lot thicker on the left side than it is on the right. And why did I say that was? That's because this side is going to be pumping, the right ventricle is pumping blood to the lungs. So they don't need too much blood. But the left ventricle needs to work a lot harder because it has to pump blood out through the aorta to the remaining parts of the body. So that means it needs to go to the upper extremities as well as the lower extremity and our organs, the remaining organs. Okay? So let's look at our valves. The valves of the heart ensure a one-way blood flow. A valve lies between each atrium and its ventricles, and at the end of each ventricle into its great artery. But no valve lies where the great vein empties into the atria. Now each valve consists of 2 or 3 flaps called cuspids or leaflets, and they're covered with endocardium. The atrioventricular, the AV, our AV nodes, atrioventricular node, our AV valves, or atrioventricular valves, they're the ones that are going to regulate the opening of the openings between the atria and the ventricles. So that's the ones you're going to find between the atria and the ventricles. And we have a right and we have a left. The one on the right hand side are considered to be tricuspid valves, and they have 3 cusps. The one on the left is known to be called the mitral or the bicuspid valve. You may have heard of mitral prolapse. That's the particular valve that they're referring to. Now they have string-like tendinous cords called the chordae tendineae, and they connect the valves, the valve cusps, to the papillary muscles on the floor of the ventricles, and their purpose is to prevent the AV valves from flapping inward. From flipping inwards, sorry, not flapping. from flipping inwards. Oops. Here we go. That's how you pronounce the word, spell it. Chordae tendineae. So those are the extensions from those cords I was just referring to. Alright, so the semilunar valves, those are the remaining 2. We have the pulmonary and the aortic valves, and they're going to regulate the flow of blood from the ventricles into those great arteries. So we're looking at into the aorta or into the pulmonary trunk. Now the pulmonary valve, that controls the opening from, let me pull them up. They control the openings from the right ventricle into the pulmonary trunk. And the aortic valve controls the opening from the left ventricle to the aorta. Now each valve has 3 cusps, and they have no tendinous cords. So please remember which 2 have chordae tendineae and which ones don't. It's very important. You have to know which ones they are. So you have another cross section. Here we have, this would be the aorta, aortic valve. This would be our pulmonary valve. Here is our tricuspid valve. And this is our bicuspid valve. So this is the left side of the heart, and this is the right side of the heart. So we notice here that the blood is kept entirely separate on the right side and of course from the left side. So if we have contamination of oxygen and deoxygenated blood, that's going to cause problems with blood flow wherever it is going, whether it's to the body or to the heart. To the body, the heart, or even to the lungs. Alright, so let's look at blood flow through the chambers. Now the blood vessels of the heart, well, they constitute coronary circulation. Okay, before I even get to that, let's deal with blood flow through the chambers. I'm skipping around, sorry. Alright, so look at blood flow through the chambers. What happens when the ventricles relax? We seem to get pressure, and that pressure would decrease inside of the vessel, inside of the ventricles. Now the semilunar valves, they would close as the blood attempts to back up into the ventricles from the vessels. Then the AV valves, they will open and blood will flow from the atria to the ventricles. And this is what's going on when the ventricles are relaxed. Now when the ventricles are contracting, when they're getting ready to pump the blood out, The AV valves, are they going to be open or closed? Most likely they're going to be closed, because we don't want, remember, those valves are just one way, so things are flowing down from the atria to the ventricles. And in order for the ventricles to successfully pump blood out of the heart, those AV valves, our tricuspid and our mitral valve, have to be closed. And that's to make sure the atria doesn't get backed up with blood. We don't want blood going in the wrong direction. So pressure will increase inside of the ventricles, and our semilunar mitral valves, which are our aortic valves and our pulmonary valves, will open, and the blood will flow out into those great arteries or vessels. Same thing. All right. So let's look at the pathway of blood. Let's start where this diagram is going to start. Let me find one. Here's one. Here we're going to have blood entering into the right atrium. Would it be oxygenated or deoxygenated? It will be deoxygenated blood. And this deoxygenated blood is coming from where? Coming from the extremities, from our organs. It's coming into the blood, into the heart. So when it comes into the heart, into the right atrium, it flows through the right AV valve, our tricuspid valve, into our right ventricle. When pressure is built up and the pressure is felt within the walls of the heart, of the ventricles, it's going to contract. And that right ventricle is going to contract and force all that blood out through the pulmonary valve, because it's going to open. So while this is contracting, getting the blood out, this is closed. This tricuspid valve closes, and blood goes outward through the pulmonary valve, out through the pulmonary trunk to our left and right pulmonary arteries. Where's it going to go? It's going to go to the lungs for oxygen or gas exchange, where it's going to pick up oxygen, get rid of the carbon dioxide, and bring that oxygenated blood now back to the heart. And it's going to bring it back to the heart via the left and right pulmonary veins. Okay? So now it's going to enter into the left atrium, full of oxygen. The atrium then will contract and release the blood, force or push the blood through the left AV valve, our bicuspid or mitral valve, into the left ventricle. When the left ventricle has felt that pressure, the bicuspid valve closes, and the aortic valve, which is right in here, opens up, and allowing the left ventricle to push that blood outward into our aorta, into the ascending aorta, then into the aortic arch. The blood is then distributed to the various organs of the body, whether these will take it to the upper extremity. Okay, and the aorta, which continues way down and starts branching off, it will take this to the organs and to the legs, where it will unload or get rid of the oxygen and pick up the carbon dioxide that is being built up in those extremities, and then return it to the heart via our superior and inferior vena cava. So take your time, read this section on how the pathway flows. how the blood flows through the heart. It's very important. You need to know this. Now let's get to our coronary circulation. Now, blood vessels of the heart, they're going to constitute the coronary circulation. So basically, the heart needs to get blood. So at rest, the coronary blood vessels, they supply the myocardium with about 250 milliliters of blood per minute, or about 5% of the circulating blood, even though the heart is only 0.5% of the body's weight. He's doing a lot of work, and he still needs a good amount of blood. Now, the coronary circulation is the most variable aspect of the cardiac anatomy, and its description is the pattern seen in 70% to 85% of the people. Now, the coronary supply begins immediately after the aorta leaves. After the aorta leaves the left ventricle. Now, a right and left coronary artery, it will lead from the aorta, which we see here. Here's our aorta, and we have a left and we have a right. This is the left side. We have a left and a right side coronary artery that goes back to the heart. And their openings, they lie right deep there in the pockets, and they form two of the aortic valve cusps. So you see right here in the cusps, those are those little holes, not really holes, but yeah, they're little holes in the cusp where blood will flow through to the coronary arteries, or left and right coronary arteries, just to supply the heart with blood. Okay, let's move on to a little more information with this left coronary artery. So that's the one we were just looking at. That's going to branch off the coronary sulcus, and that's going to be under the left auricle, and divides into two branches. Now we have an anterior interventricular branch, and we have a circumflex branch. The anterior ventricular branch, also called the left anterior descending branch, it travels down the anterior interventricular sulcus to the apex, which is rounds the bend, and then travels a short distance up the posterior side of the heart, where it joins the posterior interventricular branch. Now, it supplies both the ventricles and the anterior 2/3 of the interventricular septum. Now, our circumflex branch, it continues around the left side of the heart in the coronary sulcus, and it gives off a left marginal branch that will pass down the left marginal and then furnishes the blood to the left ventricle. So I'm going to jump ahead 2 slides so you guys can actually see the diagram. This one's talking about the right coronary. So if you've already printed off the PowerPoint, just keep this one close by to write any extra notes on it when I talk about it. So let me jump one more. And here we are with this particular diagram. Here's our circumflex branch, and here is our anterior interventricular branch, also called the LAD, the lateral left descending. So remember I said that the left coronary artery right here is coming straight from the aorta. Okay, remember in that other view, the cross section, you saw those two little holes in the valves, in the cusps of the aortic valve. This is what it looks like on the outside. So this is dealing with the blood supply to the heart itself. So we have our left coronary artery, or LCA. So it's going to travel through the coronary sulcus, under the auricle. Here's the auricle here, and it divides into two. We have our anterior interventricular branch, and we have our circumflex branch. And this is the one I was telling you about, where it's going to travel down the front part of the interventricular sulcus, okay, to the apex area, and it's going to round the bend just a short distance, very shortly. So it doesn't stop here on the anterior view. It goes around just a little bit and up the posterior side. Now when it joins with the posterior, and this is where it's going to join, so once it goes around, it's going to start joining with the posterior interventricular branch. So this is our posterior view and this is our anterior view, and these two are going to join. And this branch, the anterior interventricular branch, it supplies both the ventricles, the left and the right ventricle, and the anterior 2/3 of the interventricular septum. Remember, the septum is inside. You'll see the cross section, and that's what separates the left and right ventricle. Then we have our circumflex branch, and that continues around the left side of the heart into the coronary sinus, which you see right here. And here's our coronary sinus. So that's little red little line you see, blood vessel, that's our circumflex branch. So it starts off in the front, it goes around and heads to the back and then to posterior view, and then it attaches and it joins with the coronary sinus. Not sinus, sorry, in the sulcus, which we are not seeing right now. And then it gives off a large marginal branch that passes down the left marginal. Here it is. Here's my left one. So here's the sulcus right here. I'm sorry, right here. Not this sinus. I'm mixing up the two. This is the sinus, but this here is the sulcus. The coronary sulcus. When I talk about sulcus, is basically a bunch of blood vessels that are together but they start branching off. So the coronary, the circumflex branch comes around the left side into the heart into the coronary sinus, sulcus. I'm mixing up the two. Sorry. Coronary sulcus, and then it branches off. It gives off a branch called the lateral marginal branch that's going to pass down the left margin, and then it's going to start nourishing that left ventricle. Now the circumflex then ends on the posterior side of the heart, and it supplies blood to the left atrium and the posterior wall of the left ventricle. So those are just the first two. Now we're going on to the right coronary artery. So we're going to deal with these here. Let's see, RCA. Okay, now they supply the right atrium and the sinus node, and continues along the coronary sulcus under the right auricle, and then it gives off two branches of its own. We have a right marginal, here it is, the right marginal branch, which runs down toward the apex of the heart, and then supplies the lateral aspect of the right atrium, and of course the ventricle. Now the RCA, the right coronary artery, it continues around the right margin, and it sends a small branch to the atrioventricular node. Okay. Then it gives off a larger posterior interventricular branch, which we see on this side, which is the red one. And that branch will supply the walls of both of the ventricles. And it ends by joining the anterior interventricular branch of the left coronary artery. So these guys are going to supply the posterior part of the ventricles, as well as join with this anterior interventricular branch. Here we go, this one here. Okay. Now, if there's any interruption of blood supply to the coronary muscle, it can cause necrosis within minutes. Now, a fatty deposit or blood clot in a coronary artery can cause a MI, which is a myocardial infarction or a heart attack. Now, some protection from MI is provided by the points where two coronary arteries come together to form a arterial anastomosis. Now, these provide an alternative route called the collateral circulation. Now, in most organs, blood flow peaks when the ventricles contract and they eject blood into the arteries, diminishing when the ventricles relax and start to fill again. Now, the opposite is true in the coronary arteries, in which blood flow increases during ventricular relaxation for three reasons. Contraction of the myocardium starts to compress the arteries and obstructs blood flow. Then during ventricular contraction, the aortic valve is pushed open and the cuffs block blood flow into the coronary artery opens. And thirdly, during ventricular relaxation, which is our diastole, blood in the aorta briefly surges back toward the blood, and some of it flows into the coronary arteries. We have a few conditions that can occur. We have angina pectoris. This is basically chest pain from a partial or obstruction of coronary blood flow. Now, pain can be ischemic of the cardiac muscle, or it can be due with obstruction partially blocking blood flow. The myocardium shifts to anaerobic fermentation, producing lactic acid, and then giving you this pain. Then we have ischemia, which is restriction of blood flow or blood supply to tissues, causing a shortage of oxygen and glucose needed for cellular metabolism, which is used also to keep muscles alive. So it's very important. We have myocardial ischemia or cardiac ischemia. This is when blood flows to the heart muscle and it decreases by a partial or complete blockage of the heart's arteries, which then leads to a reduction in the O2 supply. And if not taken care of properly or right away, it can cause a heart attack. And what causes it? We have damage to the myocardium, we have reduced efficiency of pump, and abnormal heart rhythms. So when we talk about reduced efficiency of the pump, I mean the pump is not shooting out or contracting as hard as it's supposed to get sufficient blood out of the heart. Then we have our MI, a myocardial infarction, sudden death of a patch of myocardium resulting from long-term obstruction of the coronary circulation. Blood clots or fatty acids, they often obstruct these coronary arteries. We have cardiac muscle downstream of blockage usually dies. Then we have heavy pressure or squeeze and pain radiating into your left arm. Some painless heart attacks can disrupt electrical conduction pathways, leading to a fibrillation and cardiac arrest, which is our silent heart attacks, occur in diabetics and elderly, but now it's occurring in healthy individuals. Some people think that they're healthy and they're not. I've heard of a number, well, I can't say a lot, but I've heard of quite a few endurance runners that just so happened to make it to the emergency room, and they were told that they had a heart attack. So it can happen in anybody. That kind of might just be genetics, but you just never know. And now our MI is also responsible for about half of all the deaths in the United States. So don't forget, it's not if you think that you're not healthy, but also in healthy individuals. Now, venous draining of the coronary circulation returns blood to the heart. We're talking about venous, we're talking about veins. Veins take blood into the heart, hence the name VEIN. And I'll attempt to draw and write it again. When you talk about veins, they take blood into the heart. And if you hear me talking about arteries, we're talking about, the T, it takes blood out of the heart. So hopefully that will help you remember what that what I'm referring to when I said when I'm about veins and as well as arteries. Right, so I'm going to try and erase this. Okay, so 5% to 10% empties directly from multiple small thibicin veins into the heart chambers, especially the right ventricle. Now the rest of the blood returns to the right atrium by means of a certain route. We have the great cardiac vein, the posterior interventricular vein, the large marginal vein, and the coronary sinus. So the great cardiac vein, they're going to supply the blood from the anterior aspect and carries blood from the apex toward the coronary sinus. Then it arcs around the left side and empties into the coronary sinus. The posterior interventricular, also called the middle cardiac, that vein, it collects blood from the posterior aspect, which is the back part, and carries it from the apex up to the coronary sinus. So take it up and take it back into the coronary sinus. Now the left marginal vein travels from a point near the apex up the left margin and also empties into the coronary sinus. Then we have the coronary sinus, which is that large transverse vein in the coronary sulcus on the posterior side of the heart, and it collects blood from all other coronary vein sources and empties blood into the right atrium. Now look at the cardiac muscle and the conduction system. Let's deal with the structure at first. Now the vertebrate heartbeat is myogenic, meaning that the signal for contraction originates within the heart itself. So I hope you guys are going to remember this, what myogenic means. It's the signal for contraction that originates within the heart itself. Now, cardiocytes are inherently autorhythmic. Autorhythmic meaning that they're solitary, isolated cells that pulsate rhythmically. Now, in terms of structure, the heart is mostly, we were talking about more of the cardiac cell, the cardiocytes. Oh, that's right. I'm sorry. Now, in terms of the structure, the heart is mostly muscle, and the muscle is striated, but is different from the skeletal muscles in terms of other respects. Now, the cardiac, more on the cardiocytes, that's the heart muscle cells. They're relatively short and they're branched, about 50 to 100 micrometers long and about 10 to 20 micrometers wide. Now, the ends of the cells are slightly branched, and through the branches, each cardiocyte contracts several others to form a network. One network is in the atrium. One network is in the atrium, and another network is in the ventricles. The nucleus is centrally located. The sarcoplasmic reticulum is less developed than in the skeletal muscle, and it lacks terminal cisternae. Now, the nucleus is centrally located. Oh no, I said that. And when it pertains to the SR, the sarcoplasmic reticulum, it does not have foot-like sacs associated with the T tubules, which are much larger than in the skeletal cells. But the T tubules, they admit the calcium channels or calcium ions to activate muscle contraction. And then our cardiocytes have especially large mitochondria. The cardiocytes are joined end to end by thick connections called intercalated discs, which are complex step-like structures with three distinctive features compared to skeletal muscle. Okay, so our interdigitating folds. That deals with the plasma membrane is folded somewhat like the bottom of an egg carton, and the folds, they start to interlock with those of the adjoining cells. Now, mechanical junctions, those are tightly joined cardiocytes, and they have two junctions. They have the fascia adherens, and we have the desmosomes. Now, the fascia adherens is the most extensive, and it's a band in which actin of thin myofilaments is anchored to the plasma membrane, and the cells are linked via the transmembrane protein. Now, desmosomes interrupt the fascia adherens here and there. These are patches of mechanical junctions between the cells. Now, electrical junctions, those are like our gap junctions, and they allow ions to flow between cells and can stimulate the neighboring cells. Now, the entire myocardium or other two atria or two ventricles, they act like single unified cells. Now, the repair of damaged myocardium is almost entirely by fibrosis, which is from scarring. Here are the cells. Here's our intercalated discs. And they do look like steps. And here is an example of our gap junctions and our desmosomes. So the gap junctions are the electrical junctions, and these are the ones that are going to allow the ions to flow through them, and then they connect to other cells. And then we have our desmosomes. Okay, and they're like those little patches of mechanical junctions between the cells. Okay. Now, in terms of metabolism, cardiac muscle depends almost exclusively on aerobic respiration to make ATP. We're rich in myoglobin and glycogen. There's a huge amount of mitochondria. That's about 25% of the cell, compared to just 2% of the skeletal muscle fibers that have smaller mitochondria. Now, the cardiac muscle is adaptable to a fuel source, getting about 60% of its energy from fatty acids, 35% from glucose, 5% from other fuels such as ketones, lactic acid, and amino acids. Now, it makes little use of anaerobic fermentation and is not prone to fatigue, but it is vulnerable to oxygen deficiency. Now, the heartbeat is coordinated by a cardiac conduction system composed of an internal pacemaker and nerve-like conduction pathways through the myocardium. The cardiac conduction system generates rhythmic electrical signals in a particular order. We have SA nodes to the AV node, AV node, atrioventricular node, then our atrioventricular bundle, or the bundle of His, and then to the Purkinje fibers. Now, the AV node is a patch of modified cardiocytes in the right atrium, and it initiates each heartbeat and determines the heart rate. The AV node, which are atrioventricular node, that is located near the right AV valve at the lower end of the interatrial septum. Now, this node acts as an electrical gateway to the ventricles, and the fibrous skeleton prevents currents from getting to ventricles by any other route. The atrioventricular bundle, or the bundle of His, is a pathway by which signals leave the AV node. The bundle of forks into the left and then the right bundle branches that enter the interventricular septum and descend down toward the apex. The Purkinje fibers, nerve-like processes, they spread upward throughout the ventricular myocardium and distribute the electrical excitation to cardiocytes of the ventricles. Now, when the Purkinje fibers have delivered the signals, the cardiocytes themselves perpetuate it by passing ion flows from cell to cell via those gap junctions. So here we have our SA node. We already said the SA node is located in the right atrium. Now, when it fires to both atrium, not just the right atrium, but to both the right and the left atrium. The signal then passes and excites through the atrial myocardium to the AV node. So this is our interatrial septum. And our right AV valve. This is our tricuspid valve. Okay, so you see where it's located. So it's going to receive the signals, or the excitation, and then it will send that electrical current down to the atrioventricular bundle, or AV bundle. You see how the AV bundle travels down that interventricular septum, which is here, separating left and right ventricles, and then descends down towards where? Our apex. Don't forget, this is our apex, that is our base. Then into our Purkinje fibers, which are going to distribute the circulation throughout the remaining aspect of the ventricle myocardium. Now, the heart does not receive both sympathetic and parasympathetic nerves that modify blood heart rate and the contraction strength. Sympathetic stimulation can raise the heart rate to about 230 beats per minute. Parasympathetic stimulation can slow it down to as low as 20 beats per minute, or even stop it for a few seconds. The sympathetic pathway to the heart originates in the lower cervical to upper thoracic segments of the spinal cord. We have preganglion nerve fibers. They extend from the core to adjacent sympathetic chain ganglia, and some ascend to the cervical ganglia. Now, if we remember, we talked about preganglia and the ganglia. Now, the postganglionic nerve fibers, they pass through the cardiac plexus in the mediastinum and continue via cardiac nerves to the heart. Now, these fibers terminate in the SA, the SA node, and the AV nodes, and in the myocardia, as well as the aorta and the pulmonary trunk and the coronary arteries. Now, stimulation increases the heart rate and contraction strength, and then it dilates the coronary arteries. For the parasympathetic, let me see if there's another one. Yep. For the parasympathetic pathways, it begins with nuclei of the vagus nerves in the medulla. Now, the preganglionic fibers, they're going to extend through the vagus nerves to the cardiac plexus, where they will mingle with the sympathetic fibers and continue to the heart via the cardiac nerves. They synapse with the postganglionic nerves in the epicardial surface and the wall. Postganglionic fibers have from the right vagus nerve, they lead mainly to the SA node. The postganglionic fibers from the left vagus, their nerve leads mainly to the AV node, but both left and right have some fibers that cross over. Little or no vagal parasympathetic innervation occurs in the myocardium. Parasympathetic stimulation reduces heart rate. The cardiac nerves carry both sympathetic and parasympathetic efferent fibers, and they can carry sensory or afferent fibers to the CNS. The latter, which is the sensory fibers, are important in cardiovascular reflexes and transmission of pain signals. Now, the conduction of the heart is called, the contraction of the heart is called systole, whether it's atrial, or the atrium, or the ventricle. Systole is contraction. Diastole deals with relaxation. The sinus rhythm, this is considered to be that normal heartbeat, and is triggered by the SA node, and is a cycle of 70 to 80 beats per minute in adults, although rates of 60 to 100 beats are not unusual. Now, stimuli such as hypoxia, electrical impulses, caffeine, nicotine, and other drugs can cause other parts of the conductive system to fire before the SA node, and that's considered to be the ectopic focus. Now, any region of spontaneous firing other than the SA node is called the ectopic focus. So if the SA node is damaged, the ectopic focus may take over the governance of the heart rhythm. So basically, that means our AV node would take over. But then that will give us a heartbeat of approximately 40 to 50 beats per minute. So the AV node is the most common ectopic focus. We have intrinsic ventricular rhythm. If the AV node and the SA node are both malfunctioning or not functioning, the rate slows down to about 20 to 40 beats per minute. So now we have the atrioventricular bundle that is taken over. And at this point in time, the person is going to need a pacemaker. Now, any abnormal rhythm, cardiac rhythm, is called arrhythmia. One cause of arrhythmia is a heart block, the failure of any part of the cardiac conduction system to transmit signals. It is usually a result of disease and degeneration of the conducting system fibers. Now we have a heart block. This is well, they have a few here, the bundle branch block, and then you have a total heart block, which is damage to that AV node. So I went into the more details with our bundle branch block, which you won't find in the textbook, but that deals with damage to both the left and the right bundle branches. So here's the left branch, and here is the right branch. So it's either one will be blocked, or both will be blocked, which is not good. So what causes it? We have heart disease, coronary heart failure, congestive heart failure, sorry. We have cardiomyopathy and hypertension. HTN is hypertension, for those that did not know. Now, some of the symptoms. We have pre-syncope. Pre-syncope is feeling like if you're going to faint. Now, syncope is actually fainting. We have dangerous bradycardia. That means if your heart rate is too dangerously low. And that usually occurs when there is a left bundle branch block, or LBBB, left bundle branch block. Now for a right bundle branch block, we have an MI, which is, we already know what MI is, myocarditis, which is inflammation of the myocardium, which is that heart muscle. We have hypertension. We have pulmonary embolism, which is a blood clot blocking the entrance to one of the blood vessels to the heart. And then we have scar tissue developed after a heart surgery. Now some more cardiac arrhythmias, as mentioned in your book. We have atrial flutter, which is an ectopic foci in the atria. Okay. And there we have atrial fibrillation, and where the atria beats approximately 200 to 400 times the per heart per minute, sorry. Then we have preventricular contractions, or PVCs. That's dealing with it's caused by stimulants, stress, or a lack of sleep. So our PVCs, our ventricles, we'll get into what these look like in a minute. Our ventricles are beating or contracting a lot faster than what they're supposed to. The rhythm is supposed to be lub dub, lub dub. They're coming in between. They're lub dub, lub dub, dub dub. So it's coming a little faster. Then our ventricular fibrillation. This is what it looks like on an EKG. Looks like chicken scratch. Look. And we have this is serious arrhythmia caused by electrical signals reaching different regions at widely different times. And the heart cannot pump blood, and there's no coronary perfusion. Now, if not taken into consideration very quickly, with defibrillation, the person can die. So already know what fibrillation is. It's a strong electrical shock whose intent is to depolarize the entire myocardium, stop the fibrillation, and reset the SA nodes to sinus rhythm. And that is the end of our part 1 of 3 series of the heart. Don't forget to post questions.